hardly any pain. If they do, it'll be like a stinging pain when you change the dressing, but more of the time, they're gonna tell you that their legs feel heavy at the end of the day where they're swollen and standing on them. That's more what they complain about. The ulcers themselves typically are just not overly painful. More burning and stinging, but once you cover those nerve endings up, they're actually quite comfortable. And you can have slough, and then here's an example. You see we have the boot. That's what that white is from, is the zinc wrap that you see on the leg. And this white is from the zinc wrap. Here's an ankle. You see the scaly skin, the brown staining on that skin. See how puffy those legs are?
I've seen somebody in Walmart the other day, and he had one leg that was like 5 times bigger than one of those.
Yeah,
I mean, it was like this big around.
we're gonna talk about that in just a second. This guy goes along with these.
He was walking around. I couldn't
They
believe
will. It's a lymphedema is what it is. Can you guys see, you see a pattern, these are right around the ankle area. You see the brown staining, very irregular. Here's another one. Okay, so we try to have patients elevate their legs, and elevating does not mean putting on a stool and just propping it up. It means higher than the level of your heart, so they have to go way up in the air. You compress them at 30 millimeters of mercury is the standard at the ankle. That's what we want to try to provide. I will tell you that if it's an older patient or they have mixed disease, which means they have an arterial problem as well as a venous problem, some of them you will not be able to compress at all, and others you will have to lower that compression to like 10 or 15 millimeters of mercury, which we do because that's all they can tolerate.
Just to give you a reference, aren't Job stockings about 15 in the hospital? They're about 15 millimeters of mercury, so that's just a reference.
When I come back, I have a wrap that I'm gonna show you, and I'll even let you guys try to put it on yourself if you wanna give it a shot, because I'm just gonna tell you, is not comfortable, okay? 30 millimeters of mercury is a lot on your legs, and it's not exactly the most comfortable dressing.
Are the Job stockings like Ted Hose?
Ted hose are different in that a Job stocking is a true compression stocking. A Ted hose actually don't compress where they're supposed to. They compress only at the calf muscle instead of being a, yes, starting down and going up in a cylindrical fashion. Gradient is the word. You have a gradient compression with the compression stocking. So really a Ted hose is not therapeutic, and ACE is the same way. ACE gives when it's not supposed to on these patients and squeezes when it's not supposed to. When they're at rest, an ACE bandage will squeeze in on you, and you shouldn't be having compression at rest. You want compression more when they're standing and walking. Does that make sense? So they have to be appropriately sized. The problem that we see in home care is most patients can't get a Job stocking on, because if you've ever tried that, it's not an easy feat. And then the second thing is it's hot, in the summer, and they'll leave it off. And then after you've left it off one day, you're too swollen to get it on from then on. So you just have to go through that whole pattern of re-ulcerating. And then they end up going back to the doctor, and the doctor calls us back in 2 or 3 months later, and we're back in the same situation where they decided not to wear it for that day. But there are other options besides Job stockings. There's a product called Juxtalite, that's a Cirque that actually uses a Velcro technology, and I have one of those I'll bring next week for you guys to see. And then there's also Edemaware, and then you can also get the pumps. If you've ever seen a lymphedema pump, it's a dynamic pump, and basically it milks the leg in a sequential pumping action of the
Oh, I've
leg.
seen those in the hospital. So they
Yes.
put on people that are in the hospital beds.
Well, those are actually very light compression compared to what these are. But yes, they're doing the same kind of action, but these will pump you hard. I mean, really hard, in an attempt to return this venous circulation. So just to give you an idea, if you want to avoid irritants and emollients on the skin, and I see people put triple antibiotic ointment and Neosporin, and it just explodes the dermatitis for these patients because they have allergic reactions. This is where you want to avoid anything that's got anything powdery, perfumey in it. It's not for these patients, because anything irritates their skin. If it's really bad, we do corticosteroids for dermatitis for about 2 weeks. If you go longer than 2 weeks with the topical steroid, what's gonna happen is the skin condition, it thins the skin, and it makes poor quality for the tissue that you have grown, that you have replaced. So your skin becomes thin, and it's very poor quality, so it's at risk for breakdown again. So you don't wanna use that for prolonged periods of time. You protect the peri-wound, we use moist wound healing. And don't assume that diuretics are needed, because one of the things that I see a lot of times as well, the patient's swollen, so we'll put them on a diuretic. You can actually have a patient with lower extremity edema that is dehydrated, because it's out in the third spaces or in the interstitial spaces, and you're giving them a diuretic, and that diuretic is acting on their kidneys. Well, if you don't have fluid back in your circulation, circulating through the kidneys, you're not getting rid of it. So they can actually be dehydrated, and you just keep dehydrating them worse by giving them a diuretic. So that's not always the answer. The compression is the answer. We have elastic and inelastic, and basically the elastic is just like it says, it's stretchy and moves. The inelastic does not move. An Uniboot, which I'll show you next week, does not move. It totally depends on the calf muscle action. And once that edema goes down, that will fall down. So you have to change it at a pretty steady frequency when you start to apply them. When we start, we change them like 3 days in a row, then twice a week, and then we get to once a week if we can, depending on the drainage or whatever. But at the beginning, you have to front load those changes, because as the edema goes down, that Uniboot will just fall down because the Coban is inelastic. It doesn't have stretch and recovery. So here is an Uniboot, just to kind of give you an idea. It's applied beginning at the base of the toes all the way up to the base of the knee. And here is showing you how it's applied in a spiral pattern. Then you go behind with Coban, and it's at about, the Coban is at a 50% stretch with a 50% overlap. Now, to tell you that I do every patient like that, if they have problems with arterial circulation, I do more like a 25% stretch with a 50% overlap. So, to give you an idea, this is what it looks like when it's on. And you guys will see many, many, many of those when you're out. And here's one that's inappropriately applied. You never, never, never apply an Uniboot directly just over the wound and then put Coban around it in the middle of a patient's. And you guys know, I mean, I know that you do ACE wraps and stuff. It will tell you in your book, if you ever wonder why you always you start low and you go high back toward the level of the heart. That's because if you roll down, you can damage the valves, the venous valves. That's the reason for that. That's why we always start at the feet and we go up with these Uniboots, is because we do not want to damage those valves. So when you get to the base of the knee, you're gonna have a piece of your wrap left. You don't roll back down. You cut that off and you stop right there. We don't ever roll backward away from the heart.
So is that what happened there? Did they do it?
They actually just decided to put it right over the wound in the middle of the leg.
And that's it?
Uh-huh.
Oh, just in that small area?
You can see it squeeze down just from where it's
And it
at.
keeps edema down and edema above. You just don't do that. You always go, in every patient, this is just for you guys to know, always at the base of the knee, at the base of the toes and the knee. That is the way it has to be applied. And, we tell our nurses, if we get an order, we just tell them we can't do that, because the manufacturer of these products do not support that, nor does the literature. This is actually the shear press compression that I'll show you, and this is examples of what will happen. This is what happens if you see this foot when you apply that Uniboot in the middle of the leg. See what happens to their foot, you send all that back down. And this is inappropriately applied because it's not got the right overlap and you get bulges. And this is where they did not use the cotton batting layer in the 2-layer compression system. When you get Pro 4 or Sure Press, and I'm gonna show you these layered compression systems, there's always a cotton batting layer, and that cotton layer protects that patient's skin from this cutting in, and it also makes a cylindrical, it fills in any deficits in their leg to get a cylindrical surface to roll up. You have a confused look.
That's more of a, oh my gosh.
Okay.
What's the A? Is that due to the limb?
That's because they applied it at the starting at the leg and didn't start at the top of the foot.
So that's the
That's
foot,
swelling.
and it's just.
Yes, because it was inappropriately applied. That's my phone, and I'm sorry for that. We'll just ignore it. I thought I had the volume
Just
turned off.
5 points.
Okay. So, here's stockings. This is a stocking donor, and this is a Circade, which you can see here, if you can see the donor, to help apply the stocking. And these are the levels of compression. When patients have lymphedema, they get up to 60 millimeters of mercury compression. That is a lot. I don't know that I would be able to tolerate that, so thank God. Here's some stockings that you can buy. They're very thin, prefabricated stockings. Just some examples. This is a dolphin donor, and I know it looks really bizarre, but I saw it at conference, and a 7-year-old was able to put on a stocking with it. So it's fairly easy. So I already talked to you guys about TED hose and ACE wraps not being therapeutic. And then here's those pumps that I was talking about. Okay, and this is a venous ulcer that progresses toward healing. You can see pretty nasty legs there. Okay, so contraindications to compression. When do you not compress? If they have unstable CHF, and that just basically, it doesn't mean if they have a diagnosis of CHF. It just means if their CHF is end-stage or poorly controlled, and they have arterial insufficiency, we don't compress them. So for Una boots, your patient has to be ambulatory. Just wanted you to know, if you use an inelastic compression, they have to be ambulatory. So with patients with mixed disease, we're very careful about that. This is a patient with mixed disease. See, there's no hair, shiny, taut skin, but they have both arterial and venous disease. Here's another patient with mixed disease. And they'll have signs and symptoms of both. You notice the toes, no hair, those thickened toes, they have signs of both.
So how do you treat in that?
The arterial takes precedence every time.
Okay.
The arterial disease comes first, okay? Because you, not to belittle it, because it's a very serious problem, and when you have venous ulcers, they're really problems, but they're kind of, for lack of a better word, bluster. You know, they look bad on the legs, but they're not life-threatening or limb-threatening for the most part. Venous, that's the venous. Arterial disease, they're life-threatening and limb-threatening, so they take precedence. Your arterial circulation always takes precedence in that case. Okay, and here's an example of mixed. They're swollen, but you can see it's pretty necrotic and nasty. So lymphedema. This can develop, basically it can be congenital or it can develop because of nodes taken out, crushing injuries, things like that. And it can be bilateral, meaning both limbs, or it can be contralateral, meaning one limb, or unilateral, sorry, meaning one limb. And it can be pretty bad. And it will progress as it continues to progress. You'll get this elephantitis of the legs. They'll look like this. Then you get severe lymphedema, which is like the gentleman probably you were talking about, you saw in Walmart. They look like this, or they just bulge out. And then you have legs that look like this. And you can see that they're lymphedema because they involve the feet too in the edema. Pretty, and they get really,
That looked like that, that's what it's like.
yeah, it's a lymphedema, that's what it is. And ideally what you have happen is you try to compress them, but you know, once it gets fairly hard and firm and you can't do anything about it, you just have to deal with it.
And he walked around and didn't seem to bother him at all.
It doesn't, it's just heavy. It doesn't hurt, it's not painful. It's lymph fluid is what it is. This is a patient in a bed. And a lot of this, I mean, it looks bad, you're thinking, oh, that patient is obese. It's not, it's lymph fluid, and they get a lot of that in there. You can even get it in your abdominal cavities. So,
Or can't you just stick something in there and drain it out or something?
it just doesn't work that way. You can't drain it out. They do some surgeries for debulking when they get really bad, but you have to be careful that you don't get into structures. I mean, it's not pleasant. The best thing to do is catch it early, go see a lymphedema therapist, get your compression garment, and don't let it go. But a lot of patients don't ever make it to somebody who knows that they should be seeing a lymphedema therapist, which is not me. I mean, I'm not qualified to do it either. That's one of the biggest referrals I send out, is I say, you have to see a lymphedema therapist, and they have to get you a custom garment, because it has to be fitted. There's one in Fort Smith.
Yeah.
So for the ones that are here locally, but I just have to find them wherever we're at, you know, to find a lymphedema therapist, because it's much more involved than just compressing them. There's manual lymph massage that has to happen, where they are allowed to empty those, you open the lymph passageways. It just is very involved, and the wraps are quite complex.
So once they get that big, there's no coming, I mean,
Not generally, it's very hard to do. You have to have a lymphedema therapist that works on it. And we're talking about years, I mean, this is a lifelong thing that they have to manage. You know, I don't know if you've ever seen patients that have mastectomies, you know, where they take out nose, their arms will do this. And they'll have custom garments that fit all the way down on their fingers, where you only have the tips that are showing, you know, and have to see a lymphedema therapist. And, you know, they'll be elevating their arms on pillows like this, trying to help with the edema. So it's really complex. Okay, so that's all. Does anybody have any questions for me? I know there's more to the presentation, but we won't touch that till the next time. More slides. Nope.
Which one do you see a lot more, the Venus or
The Venus by far, well, overall, because I cover numerous states for what I do, I see mostly venous, but in our area, by far, you will see more neuropathic than anything. Because of the diabetic population, you'll see a lot of that. Sometimes and sometimes not, just depends. Yes, as far as job security, I mean, you get jobs. I mean, I do get that. People say you want to work in the hospital, you want to work here, but I'm very unfortunate, I get to work out of my home. So, and I do everything usually by digital photos and consulting, so it's really nice. I mean, I get to, stay home and be able to do that for the most part, so I like that part of it. I do have to travel some, so.
Well, you definitely know your craft, so you probably sound like you might try and pick it.
Well, the thing about it is, it's an experience thing, and once you, use your experience, you know, you, just like dressing. When you talk about dressing, at first, it's gonna be very overwhelming. But after a while, you use them and you start to know, you get more comfortable with it after you do them. I mean, I've seen almost so many wounds, it's unreal how many
I
wounds
believe you
you
after
see.
what I've seen today. Wow. For what? I said crap. Why would I say that? I didn't even say that. That has nothing to say.
You better appeal.
Everybody meeting last Thursday with no
Crap.
Crap.
Like crap cheese.
That's a good macaroni.
Hey, I got false teeth, you know, it's hard to say words correctly.
You're welcome, thank you,
Yeah, that was very interesting.
thank you. Thank you. I'm coming. There, just a minute.
There's only one way. But not like that.
Hear me?
Not like, I'm not gonna say anything about it. It's 60 pages, top is right.
I'll tell you what's that video.
Have you changed this to make it in the outline form for rid of other pictures?
That's what Bill's watching.
Get rid of the pictures.
Choose your new thing, you know. Bill's watching. What, Bill?
You know, he's gonna have it on camera.
What are you gonna take notes on?
These are my notes. It takes it to 38 without the pictures. With 9, or it just goes outline?
38 slides?
38 pages.
38 pages.
Can you
Oh.
just get the notes and block out some of that?
Yeah, it takes 38, it's 38 pages.
38 pages. It's just, I mean, it's pretty good information. If you wanna go through and take down some of the things that you think are important. I'm gonna tell y'all, that's the best presentation on wound care that I have ever seen, and that's why I bring her in here. I hope y'all appreciate. She's probably the best wound care specialist I've ever dealt with. And I've had numerous of them in here doing this, and she does an excellent job. So, I mean, she's really giving you some great information.
We're underappreciated
I
at the
know,
moment,
she
but she does.
pushes it in there, she does.
I didn't wanna go get a wheelchair when we were in here.
Go back and read over it before the next 3 weeks will help, but I know you'll have tests this week. You can't read over it.
Are we having a test over just wound care?
It'll be on, it won't be on this test, it'll be on, I know. So, yeah, probably pretty much just wound care. I think family is wound care.
So, I thought you said that you were on another test before the breakdown.
We're not. We're not.
I know, right.
Wounds will not be on midterm, but she won't be here until after midterm, she's coming to 7 o'clock.
It makes me feel a little better.
She's gonna teach us.
Because I said it.
don't mean that you're unappreciative, I just want y'all to appreciate what she is giving you. It is
That's
it's
why-
really excellent
And
stuff.
that's why someone made